Hello everyone and welcome to our module on gout. Gout is a disorder in which uric acid deposits in joints. Uric acid will complex with sodium, and when it does so, it's called monosodium uric acid, and this forms crystal structures that deposit in joints. And when they deposit in joints, the crystals are phagocytosed by cells like macrophages and neutrophils. This triggers an inflammatory response, and as a result, patients who have gout have recurrent attacks of acute arthritis when the uric acid crystals deposit. This leads to severe joint pain, redness, swelling, and warmth, all the symptoms of acute arthritis of a joint. One way to think about gout is that in order to get this disorder, you basically need three things. First of all, you need hyperuricemia for some reason, and we'll talk about many causes of hyperuricemia in this video. Secondly, you need cool temperatures, so gout is not going to happen in the middle of the abdomen, it's going to happen in joints that are far away from the body, and therefore they are relatively cooler. And then finally, you need a genetic predisposition. So some people with hyperuricemia do not develop gout, other people do. That's got to do with our genes. The most common location for an attack of gouty arthritis is the base of the great toe. When gout occurs here, it's called podagra. This is a picture of someone with podagra on the screen here. This patient has arthritis of the first metatarsal joint in the foot. That's podagra, a classic location for gout because the temperatures are relatively cool here. Another classic location is in the knee, so an acute attack of arthritis in the knee often represents gout. Patients who have had multiple attacks of gouty arthritis can develop what's known as tophi. Tophi are uric acid collections in the connective tissue, and when patients develop tophi complicating gout, their condition is called chronic tophaceous gout. So places that the tophi often form are the ears, the tendons, the bursa. They're usually not painful or tender, but the patient will notice a little bump, and that is a collection of uric acid called a tophi. Usually these bumps form following several attacks of gouty arthritis, and as I said before, they're seen in patients with long-standing hyperuricemia and multiple attacks of gout. Here are some pictures of tophi. This man has one on his ear. This person on the right has one on the knee. And remember, these aren't painful, but they're going to be noticed by the patient. They're going to come to their physician and ask what these represent. Long-standing gout can lead to kidney problems. This is called urate nephropathy or gout nephropathy, and there are many different kidney problems that have been described in patients with gout, but they all relate to the deposition of uric acid crystals in the urine. Two of the complications you should definitely be aware of are that patients with gout can develop uric acid kidney stones. This is a rare type of kidney stone, and I talk about it in detail in the renal section, but just know that patients with gout can develop uric acid kidney stones. And then secondly, patients with long-standing gout often develop chronic renal failure. They often have diabetes and hypertension in addition to gout, but the uric acid crystals in the urine contribute to the chronic renal failure. Sometimes these patients end up on dialysis from end-stage renal disease. You will read in your textbooks about primary versus secondary gout, so let's talk about that now. Primary gout is gout that occurs not caused by some other disease or medication. The exact cause of primary gout is unknown. It's often called idiopathic gout, but most cases are believed to be related to under-excretion of uric acid. I've cited a journal article at the bottom of the screen here if you want to read more, but people have found that in many patients who have primary or idiopathic gout, they are under-excretors of uric acid, and this leads to hyperuricemia, which can trigger gout. Secondary gout, on the other hand, is caused by a disease or medication, and there are many causes of secondary gout. In other words, there are many drugs or medical conditions which predispose patients to developing secondary gout. Most patients who develop gout attacks have hyperuricemia, and hyperuricemia can occur if uric acid is overproduced or if it's underexcreted. And as I told you on the last slide, many cases of gout are associated with underexcretion of uric acid. So let's talk about uric acid excretion now. Uric acid is largely excreted by the kidneys and the urine, and what this means is that any condition which reduces the glomerular filtration rate will reduce the uric acid excretion. This can lead to hyperuricemia and therefore can lead to gout. So patients who have renal failure are more likely to develop gout because they under-excrete uric acid. Patients who are volume depleted are more likely to develop gout, and a classic scenario for a patient to develop a gouty attack is to develop it after a hot day when they were volume depleted. Any patient that takes diuretics is at increased risk for a gout attack, and that's because diuretics decrease the glomerular filtration rate. Also, many of them directly interfere with uric acid secretion, and so for both of these reasons, diuretics often lead to gout attacks. All of these things, renal failure, volume depletion, and diuretic therapy, are commonly associated with gout attacks, and that's because they all impair the excretion of uric acid. You can also get hyperuricemia and gout from overproduction of uric acid, so let's talk about how uric acid is produced now. Uric acid is derived from purine nucleotides. You can see that uric acid has two rings in its structure, and those two rings derive from things like adenosine, which has the base adenine as part of its structure, or guanosine, which has the base guanine as part of its structure. These molecules are broken down into uric acid. The way purines are broken down into uric acid is that first purines are converted to hypoxanthine. Hypoxanthine is a two-ring structure similar to the bases adenine and guanine, and then hypoxanthine is converted into uric acid by an important enzyme called xanthine oxidase, which we'll talk about later because it's related to causes and treatment of gout. So uric acid comes from purines, but where do the purines come from? Well, some purines come from the normal turnover of cells in our body, but some other purine sources are listed on this slide. And if you understand these, it's very easy to understand what triggers an attack of gouty arthritis. So red meat contains lots of purines. Red meat is the muscle tissue of animals. It contains their nucleotides and DNA, and when you consume that, you consume purines, which become uric acid. Seafood also contains the meat of fish, and that contains nucleotides, and that leads to a purine load for the body. And then finally, if you have trauma or undergo surgery, there's breakdown of tissue in our body, and this leads to purines in the bloodstream and in tissue beds, and they get broken down into uric acid. And all three of these things are classic causes of a gout attack because they all lead to a purine load in the body, which leads to a uric acid load. Consumption of alcohol is a classic trigger for an attack of gout, and there are a couple of reasons for this. First of all, metabolism of alcohol in the liver consumes ATP, and the A in ATP is for adenosine, which is a purine nucleotide, and so when ATP is metabolized, this generates purine nucleotides like adenosine, and they are converted into uric acid, which can cause a gout attack. The other reason has to do with a transporter in the kidneys called urate transporter 1 or URAT1. This transporter reabsorbs uric acid from the urine, and the activity of URAT1 is increased in the setting of lactic acid, which is produced by alcohol metabolism. And so when URAT1 becomes more active, there's increased reabsorption of uric acid. So what this means is consumption of alcohol can lead to lactic acid production, and this can lead to a high serum uric acid level by increasing the activity of URAT1 in the kidneys. Primary gout is also more common among males, and it's also more common among obese patients. So the classic case of an attack of gouty arthritis is an obese male who goes out to a steak or a seafood dinner and consumes lots of alcohol. This patient is setting themselves up for a high uric acid level and an attack of gouty arthritis. Now let's talk about some causes of secondary gout. So uric acid excretion is mostly via the kidneys and urine, and if you understand this, then it's easy to understand a number of the secondary causes of gout. Anything that lowers the glomerular filtration rate will lead to less uric acid excretion, and this can lead to an attack of gouty arthritis. So patients with renal failure commonly develop gout. Patients who are volume depleted have a decreased GFR, and they can develop gout. And then finally, patients on diuretics commonly develop gout. Diuretics do two things. They lower the GFR because they decrease intravascular volume. They also block uric acid secretion in the urine. So for both of these reasons, diuretics can lead to an attack of gouty arthritis. All three of these things shown in this slide are common causes of gout attacks, and it's all because they affect the excretion of uric acid via the kidneys or the urine. Patients with myeloproliferative disorders commonly develop gout. So in the hematology section, I have a video on these disorders where I talk about chronic myeloid leukemia, essential thrombocytosis, and polycythemia vera. All three of these disorders are associated with high levels of cell production and cell turnover, and anytime cells are turning over rapidly, that leads to more metabolism of purine nucleotides, and that leads to hyperuricemia and gout. It's very uncommon for children to develop gout, but one reason they can develop gout is if they have a rare enzyme deficiency syndrome called the Lesch-Nyhan syndrome. This is caused by an enzyme defect in the purine salvage pathway, and I talk about the purine salvage pathway in detail in the biochemistry video on purine metabolism. This is an X-linked genetic disorder that leads to absence of an enzyme called HGPRT, which stands for hypoxanthine guanine phospholipid transferase. If children are born deficient in this enzyme, they have excess uric acid production. I'll show you why in the next slide. This leads to what's known as juvenile gout or gout among children. Now, in addition to the gout, these children typically have severe neurologic impairment. The mechanism of this is unclear. So they classically display hypotonia of their muscle and chorea, which is abnormal movements. They also classically display self-mutilating behavior. So the classic presentation in a board question is a male child with motor symptoms and self-mutilation who also has gout. The purine salvage pathway is a pathway that can recover hypoxanthine and turn it back into purine nucleotides like AMP and GMP. What the enzyme HGRP does is add hypoxanthine to a structure called PRPP and create inosine monophosphate, or IMP. This can then be converted into AMP or GMP, which are purine nucleotides. The enzyme xanthine oxidase can break down hypoxanthine, as I told you before, into uric acid. So if children are deficient in HGPRT, they cannot salvage their purines, and therefore they are all converted into uric acid via xanthine oxidase, and that leads to hyperuricemia and gout. Another rare cause of secondary gout is von Gierke's disease, which is also called glycogen storage disease type 1, and I talk about this disorder in detail in the biochemistry video on glycogen. In von Gierke's disease, children are born with a deficiency of the enzyme glucose 6-phosphatase. This leads to symptoms in infancy. Von Gierke's disease usually presents at about 2 to 6 months of age, and the clinical features are dominated by severe hypoglycemia between meals because of defective glycogen metabolism. These babies will develop seizures, and they can develop a lactic acidosis through the Cori cycle. And as we talked about before, anytime you have an increase in lactate, that can lead to an increase in uric acid. That's because the excretion of lactate and uric acid are linked via the uric acid transporter URAT1. Let's talk about the diagnosis of gout, which is done via arthrocentesis. This involves inserting a needle into the synovial fluid of a joint and sampling the synovial fluid. In gout, the white blood cell count is elevated, usually 20,000 to 50,000. A normal synovial white count is less than 200, so this is markedly elevated. And then when you examine the synovial fluid under polarized light microscopy, you can visualize the uric acid crystals. Let me briefly explain polarized light microscopy. Normal white light is unpolarized. This means that the light waves vibrate in random directions. But if you use a special tool, you can filter the light and create polarized light, where the waves vibrate only in one direction, and then you can bounce the light off an object and see how it is reflected. Objects that are isotropic reflect the light in the same way in all orientations. So for example, you can imagine an object that's shaped like a ball. No matter how you bounce the polarized light off it, it will reflect in the same way. But objects that are birefringent, like gout crystals, will reflect polarized light in two ways. That's why they're called birefringent. And the reflection is based on the orientation. So when they are parallel to the light rays, they will reflect in one manner, and when they are perpendicular to the light rays, they will reflect in a different manner. Gout crystals are described as negatively birefringent, and they get this name because there are two reflections of polarized light. So if the polarized light hits a gout crystal and the crystal is oriented parallel to the light, that will create one color. If the light hits the crystal when the crystal is perpendicular to the polarized light, that will create a different color. So there are two reflections of polarized light. Hence the crystals are birefringent. They are called negatively birefringent because the change in index of refraction going from parallel to perpendicular is negative. You don't need to know the physics behind this, but that's why they're called negatively birefringent. And what this means as a practical matter is that the gout crystals will appear yellow when they are oriented in parallel to the axis of polarization, and they will appear blue when they are oriented perpendicular to the axis of polarization. And the way most medical students have remembered this for years is that the word yellow has two L's and the word parallel has two L's. If you could just remember that, you can remember the colors based on orientation of the crystals. So here's a picture of what gout crystals look like under polarized light. First of all, note that they are needle-shaped. That's the classic description of gout crystals, long and needle-shaped. Note that some of them are yellow and some are blue, and the reason they have different colors is because it depends on the orientation of the crystals relative to the polarized light. And that concludes our video on gout.